Cover me!
Well, hello again, everybody, and welcome back to the United States Border Patrol Academy's podcast. Here with us today is the Chief Medical Officer for CBP, Dr. Tarantino. Doctor, thanks for joining us today.
My pleasure. Thank you for having me.
So, you are the first Chief Medical Officer that CBP has ever had. And when most people think about a law enforcement organization, they don't typically think about that aspect of it. What exactly is a Chief Medical Officer? What's your role in one of the largest law enforcement organizations in the world?
Yeah, well, thank you. I'm still charting my path a little bit, but so far I can tell you that the CBP senior leadership has really recognized the importance of medical support to the CBP mission, medical support to operations, medical support to the workforce, and medical support to persons in custody. And that's a growing responsibility on the operations side, workforce side, and persons in custody. CBP has about 40 lines of medical effort. Taking care of persons in custody, taking care of our workforce, taking care of our EMS program, emergency medical services program. We have approximately 1,800 EMTs, making us the largest EMS program in all of DHS. We have flight medicine, we have dive medicine, we have medical quality management, we have medical reporting, we have any number of lines of effort going on any given day. So the leadership thought it's really important to really build out the professional medical direction and oversight of that. And so the CMO position is responsible for medical direction oversight of our medical support efforts. And also I'm building out a team to help out with that, a medical officer for Border Patrol, a medical officer for OFO, a medical officer for AMO, a public health officer, a behavioral health officer, an EMS director. So a lot of exciting things going on. And of course, now I and this team are able to respond to COVID as well and play a very lead role in COVID response, again, to operations. How is COVID impacting our operations? Also our workforce and persons in custody. So that's been a big part of the job as well.
And let's take that down to what the first responders can resonate with. So you said 1,800 medical trained personnel. If we were to look at an EMS service within the cities someplace or a fire department, 1,800 is a massive, massive agency in anybody's standards. And providing medical direction and oversight to that many people with that kind of scope all over the nation, that's a big responsibility. Kind of speaks to why CBP needs somebody like you.
Yes, and it can't be just me, and that's why I'm bringing in some other physicians. I'm bringing in EMS medical director to help direct that program because it is really remarkable. I mean, CBP is obviously around the whole country and stationed out throughout the country. We have medical personnel who are conducting rescues on any given day. If you read the significant incident reports, there's almost every day there's some sort of rescue, some sort of medical response, often multiple, and then many that don't even get reported because they're just kind of addressed and then move on. So absolutely to make sure the training is in place, the quality is in place, the equipment is in place, and it's not just approximately 1,800 EMTs. We have paramedics, and then as you know, we have the BOR-STAR program and our Austere paramedic program. Our Austere paramedic program is a real sort of upper echelon of medical capability in terms of tactical medicine as well as austere remote paramedic medicine. That's a real elite team, comparable to some of the most elite teams in the U.S. military. And so to properly oversee and direct and manage all that, we really need to have the professional medical direction in place, which we're building out.
So you hit on two things, and I want to go back to the job opportunities for somebody in CBP in a second, but I want to talk about this rescue aspect that you touched on. This is kind of the unseen mission for the men and women that go out on the front line in CBP every single day. Literally every year we have hundreds and hundreds of rescues, and that doesn't count the EMTs and paramedics when they respond many times as first responders in their communities while wearing this uniform. I have to think that there's probably thousands of incidents like that take place every single year. that mission and what we contribute to the community on that side of things makes CBP even more special in my mind.
Absolutely. And it's kind of another reason to build out this medical team so that we can track that even closer and sort of capture those statistics and tell that story better than we have been, because it is a great story. Our agents and officers are out there all day, every day. And sometimes it's an agent or officer who isn't even EMT trained, but will participate in a rescue or put themselves on the line to help someone out. And so we're trying to capture that more. We're starting up an award, the Chief Medical Officer's Lifesaving Award for our personnel that engage in these rescues and life-saving efforts. And something that we definitely want to capture and tell that story a lot better about. And it could be on any given day. I read all the reports. More and more naloxone saves. We have the naloxone program, and we're saving people out there by using the naloxone, AEDs, tourniquets, things that we learn in our trauma, trauma field care, the IFAC kits and things like that. Those are being utilized out there, and we're saving people's lives.
And especially in many of the border communities are remote, just by definition. Whether we're talking about the southwest border, we're talking about the northern border, and many of us that wear this uniform have obviously had a chance to work in several of those areas. And I personally can attest, having been up in the state of Maine, and some of our men and women and their station assignments, the communities that they live in, they may not have EMS that's 24/7. It may be all voluntary. Or they may not have police departments for the towns. They rely on the county sheriffs, one or two on duty at any given time for the county. And so they literally are the first call when somebody in that community needs help. And they respond. This training that they're able to do because of your office affords them the ability to help their communities in ways that we probably didn't think about before.
Absolutely. And that's why we're trying to sort of refine and enhance our tactical medicine training for agents and officers, as well as our EMTs and paramedics. And a lot of that starts here at FLETC. I know some of that training starts here and is going on here. We want to help enhance that and provide subject matter expertise to that.
So, Doc, let's talk a little bit about a point that you touched on earlier, the jobs that are available. So when somebody joins CBP, either as a CBP officer or a United States Border Patrol agent or an Air and Marine interdiction agent, they start off in their basic roles, but there are opportunities for them to segue into areas that interest them. One of them is the emergency medicine opportunities that are out there. You mentioned the Border Patrol Search, Trauma, and Rescue Team. It's one of the premier search and rescue organizations in the country. We have a vast EMT program. There's all these jobs that create little niches that a person can gravitate to if they're interested. Talk a little bit about what's available to somebody that joins CBP and that may be interested or have a background in emergency medicine.
Absolutely, and that's another area that I want myself and my office to engage in, is to really sort of enable and facilitate these sorts of opportunities. It can start at first with just being a first responder, a medical first responder, getting some training and being familiar with things like the IFAC kit and with the AEDs, CPR AEDs, and naloxone. That's a very potent arsenal of assistance right there. And then on top of that, you can get through CBP or on your own in the community or through CBP, you can get your EMT certification and become an EMT as a collateral duty. It doesn't mean that you become a full-time EMT. You're still an agent or an officer first, but you can get very engaged in EMT work, and that's available in AMO, OFO, and BP. Border Patrol has the largest and the highest number of EMTs, but OFO is building out their program and expanding, and AMO as well, and that's something that we're going to be a part of facilitating. So that's the EMT basic level, and you can do a lot of amazing work in that area, and you'll get some experience and utilization through that. You can step it up to an EMT advanced through additional training, or up to a paramedic. And then also we have some of our special units like the BORSTAR team, which is obviously they're agents and they have that training, but they get specialized tactical training, specialized search and rescue training, as well as additional medical training. And that's a very powerful combination. And they're the ones who are out on the tip of the spear doing these rescues in remote locations. But even on top of that, we have the Austere paramedic program, where you're already an agent and then you're a paramedic. Then we give you additional training to make you a so-called austere paramedic, which we give you very highly specialized intensive training so that you can function remotely without direct medical support for 24, 48, 72 hours if you find yourself cut off or in some really remote location. And it teaches a lot of independent medical practices and techniques through protocols. And so that's a very elite kind of tip of the spear capability set that some of our agents have as well.
And you mentioned the IFAC, which of course is individual first aid kits, and that's some of the basic training that all agents get here at the Academy. And because the areas that we're asking them to go work is austere, it's some of the remote, the most remote and most dangerous areas in the country, particularly along the border areas. And so the ability to exist and function in any of these capacities for prolonged periods of time is critical, because they may be hours before assistance can arrive, EMS, life flight, the fire departments, simply by nature of the fact that they're working in these locations.
Exactly. And so I think that the FLETC, the Artesia Academy here, has a real important role to play to build that initial capability set in the trainees, because they're going to go straight from here out to the field and they might find themselves out in a remote emergency situation. So the training you get here, again, the basic skill set of the basic first aid, the CPR, the AED, the IFAC training, the naloxone training, that's a very powerful set of tools that then post-academy, you can continue to build on that. And my team and I want to continue to make those resources available to help support the basic training at the academy, but then also career-long training opportunities if people are interested.
And so, just so everybody knows, if you are interested and you're looking to join the Borstar team or become an EMT, those opportunities exist once you go through the basic academy for Border Patrol or OFO or for Air and Marine. Typically, there is a time and service requirement. I think for Borstar, it's still 2 years. I'm not sure if that's the same for the EMT program right now. But key is you do need to join and become a officer or agent and then put in for these positions, which they're available to anybody. Once if the mood strikes you and it's something that you're interested in, then by all means, we need all the help we can get out there. And you can see that we're doing everything we can to invest in it, to include having a chief medical officer. And let's talk about you, Doc, for a second. So you come to us by way of being a career Navy man with extensive credentials in the medical community. You spent a lot of time working with the Marine Corps.
Yes, sir.
And you... Let's see, it says Executive Director for the Yellow Fund, Senior Physician for Medical Planning and Preparedness, International Medical Corps, the Associate Director for Uniformed Services University. So this is not your first walk in the park.
No, I've had an interesting and kind of a varied career path through the military, through a lot of operational assignments, and then a couple of interesting assignments after I left the Navy with I worked with International Medical Corps, which is a global humanitarian organization. So we did a lot of global humanitarian work on Ebola and other things. And then I ran a veterans nonprofit for a year. But then I saw this opportunity in CBP, and it looked like a great fit for me. And I'm in about my third year now, and I've been able to sort of learn the culture and learn the operations and use that to really get leadership behind really building out the medical support. And I've been drawing on lessons I've learned from the Marine Corps. I was the director of medical programs for the U.S. Marine Corps. I've had other similar leadership positions, and I'm trying to bring some of that experience and expertise to the unique culture of CBP and the unique cultures within CBP of Border Patrol and OFO and AMO, and the unique operational requirements. So it's a fun, exciting time. Obviously, we have a lot of challenges right now with COVID, and then also the ongoing sort of migration surge at the southwest border. But those only have made our medical support efforts even more important.
Absolutely. And so you come to us at really an opportune time based on your background experience, having dealt with things like Ebola, Zika, HIV outbreaks. So dealing with a pandemic, unfortunately, is nothing new for you, but it's experience that could not come to CBP at a better time given the COVID environment that we find ourselves in right now.
Yes, and I wasn't expecting it, but I did know early on. I began to see that CBP is kind of exposed to and deals with public health and infectious diseases on a daily basis at our borders, at our ports of entry. It might be scabies, it might be tuberculosis, it might be possible measles. So that's part of the day-to-day life for CBP. And of course, CBP has dealt with pandemics in the past, with the Ebola scare, with SARS, with H1N1, going back over the years. So there was some preparation in place, but this COVID pandemic is so unique and pervasive that it's really required some real new approaches and processes and protocols. And it's been very interesting and rewarding to work on that, because I feel like CBP has really responded well, kind of set the standard for all other DHS agencies, let alone other in the U.S. government. From day one, CBP leadership brought me in and made sure that our emphasis was workforce health and safety are our top priority. We got to continue our operations, but workforce health and safety are our top priority. And we've been very aggressive in that from the beginning.
Absolutely. And I think that I'd be remiss if I didn't ask some questions for everybody listening that might want to know. So one of the things that we've been doing is kind of learning how to live with COVID in our daily lives. And some of that has been preventative measures, PPE, things that we have to do. Let's talk about the mask. So explain for once and for all, from a medical doctor, why are masks important and what do they do?
Yeah, that's a great question. And to really get into it, you have to even break it down to what do we mean by a mask, because that can be confusing to people also. So there's cloth face coverings, which could be a bandana or a gaiter or homemade masks that are made out of fabric. That's one level. Next level up would be surgical face masks. And then next level up would be N95 respirator masks. And they serve different purposes and they have different levels of functionality. The N95 is considered PPE, it's considered personal protective equipment, and it's meant to be fitted, it's meant to have a seal, and it's meant to provide very good protection for the user as well as people that person might be exposing. And we have very clear standards and guidance in place through our job hazard analysis of where and when the N95 and PPE and things should be worn, depending on the risk, the exposure risk, the duration, the job task, all of that. So that's the N95s. But throughout the course of this epidemic, a lot of research, and we're still learning about this virus, but the latest advice and guidance from the CDC and the research is pointing to the efficacy of cloth face coverings or surgical face masks in protecting people from exposure. Number one, you want to practice the proper hygiene. Wash your hands, don't touch your eyes, your nose, your mouth, and take proper precautions in that regard. Number two, you want to maintain the social distancing, 6 feet apart, avoid large groups. But then on top of that, the mask use has been shown to be effective, whether it's a surgical mask or a cloth face mask. Mostly the thinking is that those masks, because they're not sealed, because they're not proper PPE, they don't protect the user as much as other people from exposure if that person happens to be positive.
Great point.
Now, there's some protection for the user, and the recommendation from the CDC and my recommendation, and CBP is making this more specific in some of its guidance, is to use the cloth face coverings and the face masks in congregate settings, in places that are higher risk, or certainly in places where you can't stay 6 feet apart. And that's been demonstrated to play a large part in kind of driving the infection rate down and the exposure risk down. So
a couple of great points there. So number one, I think it's important for everybody to understand that the mask is not itself the panacea. It's not the end-all, be-all that's going to solve all the problems. It's used in conjunction with other things that we do to keep safe.
Right.
You also made mention of the fact that the surgical masks and the cloth coverings, they actually probably do more to protect everyone else from you. So you're wearing it as a courtesy to help protect other people. Is that accurate?
That's the kind of current state of the thinking on it. And that's kind of what the current evidence is pointing towards, yes.
Okay. And so the 6 feet rule, So we've seen these in pretty much every building we go in now, every store, and you toured the base with us right now and got to see what we have here at the Academy. On the floor, it marks out 6 feet, so everybody stays 6 feet apart. What does that do? What is that all about?
Yeah, that's a great question also. And a lot of that, and even some of the mask use data, some of the 6 feet data preceded the COVID. It was based on studies of other infectious diseases, and a lot of it is done by some very detailed technical research in the labs where they can actually monitor the distance that a respiratory droplet travels versus an aerosolized particle. And it's thought that largely COVID is spread through respiratory droplets, and that it's known that the risk of transmission of those diminishes dramatically at the 6 foot mark. Actually, it drops off considerably at the 3 foot mark, and then it goes lower and lower by the time you get to 6 feet. So 6 feet is actually kind of being a little extra cautious from the 3 to 6 feet range. And so it's based on a lot of pre-existing science and data. It's not obviously 100% perfect rule that 6 feet is exact in every situation. It's a guideline that comes from the science, and the approach and the thinking is to decrease that direct spread from respiratory droplets, which is the primary means of exposure.
Okay, and really, these two things, wearing a mask, ensuring the 6 feet, social distancing, washing your hands, keeping your hands away from your face, it takes all of those things together to be the most effective. It's not any one thing that we do, which is why we have these things implemented across our organization, and you'll see it in the communities as well. They're asking us to do all of those things because really to be the safest that we possibly can and prevent that exposure, we need to be doing each and every one of those. Is that?
Absolutely. And I would add a couple other elements to that. The isolation is if you feel sick, if you have symptoms, you need to stay home or isolate and not expose anyone else. Seek care, talk to your supervisor or your instructor, and consult your medical provider. So if you feel sick, have symptoms, you got to isolate yourself and get that looked into. That's on the isolation side. Then there's the exposure side. If you've been exposed or you think you may have exposed someone, that needs to be tracked down as well, because those people need to go into quarantine for 14 days, now possibly 10 to 14 days, to avoid exposing additional people. So those are really important pieces of it as well. If you feel sick, if you have symptoms, stay home or stay in your room, isolate yourself. If you've been exposed or have exposed someone, you need to follow up with the exposure risk assessment, the contact tracing. The CBP's put out very clear guidance on that as well as part of our COVID toolkit. And I know there's processes and procedures here at the Academy for that as well.
And you talked about something that I want to go back to. So, and this probably is true for you coming from the military, but here in the Border Patrol and CBP and just in general, and I think probably translates to most first responder agencies and law enforcement. The culture is to push through, to be tough, to be strong. And so when it comes to being sick or taking a sick leave day, our culture taught us to show up, because if you don't show up for work, you're doing a disservice to your teammates. You're making them pick up your slack. That's turned on its head today. Today we actually are telling the reverse story. We're saying if you show up to work feeling sick, you're putting your teammates and friends in harm's way. That's something that we need to kind of be adopted throughout the entire organization to really have that impact. Stay home if you're sick. Don't show up to work. Nobody's expecting you to be tough.
Absolutely. And and we've tried to put in place policies and procedures to facilitate leave if someone has or has been exposed to COVID. But absolutely, it's important to sort of, it used to be like you're saying, it used to be, take one for the team and come on in and gut it out. Now it's take one for the team by staying home and keeping your coworkers safe, but also the operations. If you go in and you expose 10 people and then they expose 10 people, pretty quickly you've shut down a station or you've shut down an academy or something else through your possibly well-intentioned desire to get in there and do your part. But the real well-intention is to stay home, get it addressed, get it taken care of. And because this is real, it can really impact operations, but also, unfortunately, we've had a number of deaths in CBP. And, for younger, healthier people, they may think, oh, it's not a big deal to me. But throughout CBP, we have some older people, we have some people who have some medical conditions, and unfortunately, we've had a number of deaths in CBP. So it's a real deal.
Well, and that's something I think about on a regular basis. So the majority of us that have it, and I caught COVID during my time here at the academy, and for me, it was like a bad head cold. I didn't have the fever and some of the other symptoms until I had the loss of taste, and that was one that was, of course, a red flag for me. Thankfully, I stayed home as soon as I started feeling sick to make sure I was practicing what I preached, and it got me thinking that while most of us probably do recover, there's always that handful that won't, that can and do die from a disease like this. And I think for any of us, the one thing that should be on our mind is we don't want to be that person that was responsible potentially for somebody losing a loved one or losing their own life because we didn't heed those warnings.
Absolutely. And, I think that's the strongest case you could make is that, and you don't want to, sort of, maybe inappropriately refer to these deaths, but the one thing we could learn from them is the need to be cautious and take the right precautions and do the right thing to protect our coworkers.
And you see, I'm wearing the mourning band on my badge right now because it's been that kind of a year. We've lost entirely too many. One is too many. Entirely too many of our brothers and sisters out there that were exposed while on duty to COVID and have succumbed. That needs to change. We need to stop that. What are some of the things that they can look for in terms of signs and symptoms that be a red flag for them to maybe think they might have been exposed and need to get checked?
Well, yeah, that's a great question. And so the risk of exposure is generally thought to be, I'll summarize it. We have very detailed guidance out this through CBP, through what's called the CBP toolkit, and I recommend that people look at that. First of all, look at the CBP job hazard analysis. That looks at the job task specific exposure risk and PPE recommendations. And then the CBP COVID toolkit has about 15 pages of definitions, and it has exposure risk assessment guidance, it has return to work guidance, it has face coverings guidance. It's a very useful tool. But in general, to simplify it, the risk of exposure is generally thought to be 15 minutes of exposure to someone that you're within 6 feet of. So again, stay 6 feet apart and don't get close to people in mass gatherings or for prolonged periods of time. If you have that, if you're within 6 feet for 15 minutes of someone with COVID or suspected of having COVID, then that's a significant exposure that you have to take the exposure precautions for. Part of which will be looking for symptoms. And so whether you're exposed or not, you need to be vigilant for symptoms all day, every day. And unfortunately, they're kind of nonspecific, but generally kind of flu-like symptoms. You could have cough, shortness of breath, fever. That's the classic initial triad of one of those symptoms: fever, cough, shortness of breath. But others have been added now. And interestingly, as you pointed out, loss of taste or smell is pretty specific for COVID. So if you have loss of taste or smell, you got to take that very seriously, and that's COVID until proven otherwise. It can also be general gastrointestinal symptoms like nausea or stomach upset or diarrhea. It can be muscle aches or pains, and it can be other non-specific symptoms. So if you're having any new symptoms that kind of fit that pattern or just don't seem like something that you know 100% what it is, then you need to presume it's COVID until you get that checked out.
That's great advice, and I'll say just kind of as a personal testimonial, where it hit me, I didn't know what to expect if when somebody talked about the loss of taste, the loss of smell. It's happened. I think somebody can more readily recognize it, but the consistency of the food was there. You could even feel the spiciness of the food, but it's like somebody muted the flavor. So however much flavor that food normally had, and I'll give you an example. If you're drinking a diet soda, you can tell that it's carbonated, you can tell that it's cold, but you may not be able to taste that flavor. It'd be like club soda. I wasn't prepared what to look for in that particular sign or symptom, and for me, I kind of had to guess. And so, erring on the side of caution, because I didn't know what to expect, I went ahead and got checked, and sure enough, That was a telltale sign, and I was thankful that day that I stayed home, went and got tested. Some of those symptoms are probably going to be a little tougher to detect. I think you always have to err on the side of caution.
That's what we're advising now. Everyone, the guidance across CBP is everyone every day should be what we call self-observing. Self-observe for symptoms, essentially every day before you go into work. Get up, say, am I having fever? Am I having cough? Am I shortness of breath, loss of taste or smell, some GI upset, muscle aches or pains, or something else that's just unexplainable? If so, don't go into work. Contact your supervisor, and then consult your medical provider and get it sorted out before you risk exposing people.
That's right. So the quarantine or isolation period. So we've heard 10 to 14 days. That's the current CDC guidelines. What's that about? What is that based on? And what do they say 10 days versus 14 days? What are they accomplishing by having somebody stay isolated for 2 weeks?
Yeah, great question. And that's, again, based on a lot of science and studies that preceded COVID, but also now it's being informed as we learn more about COVID specifically. And it's looking like the infectious period, which means someone has COVID. What you're interested in is the period of time that they can get someone else sick. And it looks like that really, the peak of that is between maybe day 3 and 7. So that's where a person is at the highest risk of spreading it. But that doesn't just go down to 0 at day 7. It kind of trails off to, by day 10, it's pretty low, but there's still some people from day to 10 to 14 who in the right circumstances can still transmit it potentially. And that's why the 14-day, CDC is now thinking maybe the risk is so low at day 10 that we don't necessarily have to have everyone go to day 14. That can be a case-by-case basis. But that's how you get the 10 to 14-day window. It's because that's where the risk of spread is going down to practically 0 during that period of time.
And you made mention of it earlier when we were talking today. It kind of boils down to how much risk are you willing to accept? And that's a great point, that it doesn't just stop from one day to the next. It still could. It's not an exact science. You said it before. At some of these junctures, it becomes more art than science as we try and find our way through this.
Absolutely.
So for the testing, again, there's multiple kinds of tests out there, and then depending on who you go to is how much time it takes to get back. How accurate are they?
Yeah, another great question. Testing is a challenging issue, partly because of availability, but partly because of expectations. People kind of come to view testing as kind of the solution whereby, it'll give you all the answers that you want to have. First of all, there are several different types of testing. There's so-called antibody testing, which can tell you if possibly you've been exposed to COVID in the past. That testing hasn't proven to be very reliable, and it doesn't necessarily, you could be negative on a COVID test, but still have COVID, and vice versa. So it's not really reliable. We're not really advocating its use very much in CBP. It might have use in certain circumstances through your doctor. So that's one testing. Then there's the diagnostic testing, which is called PCR testing. It's the state of the art. It's the most sensitive. It's the most specific. But unfortunately, it still takes 2, 3, 4 days sometimes to get those results. Then there's the rapid testing, and that's called antigen testing. It's looking for evidence of the virus, but not necessarily the virus itself. And that can be turned around in an hour. Some testing is now coming out that's home use. That's on the horizon where you can self-test at home. But those tests aren't as reliable as the diagnostic testing. The diagnostic testing is very reliable, but it can still have false positives and false negatives. It can a certain test could say you're positive when actually you're not. Maybe what that might mean is it's so sensitive, it's picking up some viral fragments that you had months ago, and you're already over it, and it's only still saying you're positive. Also, it might say you're negative, but yet you just haven't converted to positive yet. And the rapid testing is even more that way. And what it means is, this is why the limitations of testing. You might be tested, and it might say negative, but actually you're in the process of becoming positive, and later that day you'd be positive. So it's not really helping you that much. And in fact, it's been shown that if you're in that kind of transitional phase, you could be test negative, but you could even be infectious at that point in time through these rapid tests that aren't as reliable. Now, it might also test you and say you're positive, but you might actually not have COVID. So for all these reasons, testing isn't like the be-all, end-all, because here's another point. Say you've been exposed and you say you've got to have your 14-day quarantine. Even if you test negative during that period, that doesn't mean you can come out of quarantine because you may just not have become positive yet. You still have to finish the quarantine. So, testing has uses. It's important, and I know that the Academy is using it to because of the unique circumstances here at the Academy, the congregate settings, the high exposure risk, and so that makes a lot of sense. In a general day-to-day operations in the field or public, testing has its limitations. Certainly, if you have symptoms, it's worth getting tested to see if that's COVID or not. But for general use, just to reassure or come out of quarantine, testing really has limitations. On the good news side, it is becoming more and more available through the local health systems in the community. Unfortunately, there's more demand right now because we have more cases, a holiday travel period, but I think testing availability will continue to increase. And hopefully, and you may be getting ready to ask me about this, as the vaccines come on board, we're going to see less need and less demand for testing.
So I do want to talk about the vaccine here in a second. But so if I can just kind of sum it up, so the PCR test is probably the most accurate of the tests that are available.
Yes.
And depending on when you get tested after your exposure could determine if you're positive or negative. If you get tested too early, you may come up negative, and you may be positive later on.
Exactly.
So I can tell you here at the Academy, we do that. We incorporate 2 different testing periods during the person's restriction of movement or our isolation period. They get tested initially, and then several days later they get tested a second time. So we actually use 2 tests during the isolation period to try and hone in and make absolutely sure that they're not contagious when they actually go join the rest of the trainees. In this kind of a setting, that's good, but it's much more difficult to do out in the open, in the public. So I think your point is don't rely exclusively on those test results. Still exercise every precaution.
Absolutely. Yeah. In sort of the general setting, testing has sort of a limited role. The real important parts of what we've already talked about is the personal hygiene, the preventive measures, the PPE, the masks, the social distancing, the isolation if you're sick, the exposure assessment, all of those measures. And testing may have a role if someone's positive through their health system to check and see if that's COVID or not, but it's not necessarily definitive.
Okay. And somebody like me had it. Am I immune for the rest of my life now?
That's another great question. We're still learning about COVID. By definition, it's only been around a year, so we only know what might happen for up to a year. There is evidence that there is significant long-term immunity from COVID exposure. It may not be 100% protective, but it would make any future cases very mild. But we're only a year out, so we don't know what happens in 2 years or 3 years or 4 years. The vaccines show evidence of at least months of immunity, and the thinking is that they're going to confer at least a significant amount of immunity, but again, only time will tell as we continue to study this.
Okay, so before we go to the vaccines, last question on that particular topic. Do people need to be afraid to be around people that have had COVID and already recovered?
Much less risk, much less concern, and at least for months after the infection, there's no to minimal risk in that period. We're still kind of waiting to see and get more data on what happens in the months to year time frame, but definitely less risk. But still, the advice, the guidance is to continue to practice the protective measures of the personal hygiene, the social distancing, the mask use, and isolation, all of those things, until we have more data and more experience.
Okay. So the vaccine. This is the hot off the press. It's rolling out. Vaccines are starting to be administered. There's the top tier individuals. Of course the people in the high risk categories, the nursing homes, and then shortly on the heels of that are going to be our first responders. And many of the folks in CBP are probably going to start to fall in those categories. Tell us about that vaccine. What does it do? What makes it effective? How does it work?
Yeah, the vaccine developments are really exciting and kind of historic in the ability to develop several vaccines in less than 9 months and get them through the research, the development, the testing, the approval, the manufacturer, the shipping, the delivery. It's really a historic achievement. And right now we have 2 vaccines you've probably heard of, the Pfizer vaccine and the Moderna vaccine. They're similar. They're very technologically advanced vaccines in that they're called mRNA vaccines. So what they're providing is just a little snippet of a copy of the genetic code of just a little part of the virus that codes for a protein in that virus. So they're going to send that. The vaccine will send that into our body. Our body will recognize that and translate that into making some of those proteins that our immune system will then be trained to attack. So if and when it ever does see the virus, it'll already be trained to respond to it and take care of it. So it's a unique approach. In the past, they've had to use actual viruses or viruses that were killed or weakened. And so this is theoretically and in practice so far a safer, a more elegant, a more direct approach. And these vaccines were studied extensively. Some people might be alarmed, well, they got them out so fast, they must have cut some corners. No, they still did all of the phase 1, phase 2, phase 3 clinical trials, which means they were tested for safety and efficacy on tens of thousands of patients around the world. And what they've shown is that both vaccines are close to 95% effective, which is historic. The flu vaccine, which we encourage people to get, is only 40 to 50% effective.
Wow.
These are light years ahead of that at 95% effective. Now, it remains to be seen how long they will be effective. Maybe it'll become an annual thing. Hopefully not. There's reason to think that the protection will extend beyond that. But so highly effective. But then safety as well was looked at very closely. And through all of those trials, they didn't see any incidents or pattern of significant adverse events. What they did see was the occasional sort of vaccine reaction, which would be a mild headache, mild just muscle aches, just not feeling quite well, very mild flu-like symptoms, similar to what you could get from other vaccines. And what that is actually a sign of is that the vaccine is working because it's stimulating your immune response, and that is creating some of these reactions. So those reactions were mild and self-limited and did not present any sort of concern for any significant or lasting adverse effects. So the safety profile is very high as well. These vaccines are being rolled out across the country as we speak, and they're being targeted to healthcare workers and nursing home long-term care residents. CBPs, EMTs, and medical personnel are going to be in that first tier of priority. And the next tier of priority will be first responders and frontline law enforcement, which we're going to make sure CBP is at the front of the line for that as well.
Interesting. So with what you know right now, do you feel comfortable recommending that people get the vaccine?
I do. And in fact, I'm going to get it myself. And as a healthcare worker, but also as sort of, to kind of lead by example for CBP to sort of use the process, but also to hopefully demonstrate confidence in the vaccine, because I think it's very important that our workforce get it. Obviously, it doesn't work if you don't get it. And we continue to be exposed on the front lines, and I don't want to see any more preventable loss of life. I don't want to see any more hospitalizations or ICU admissions, and I want to get this out and have it accepted by our workforce. And I think, I'm glad to lead by example on that. I feel very confident about the safety and the efficacy of it, so I would recommend it.
Okay, and so potentially it could turn into a seasonal shot. It could also be a one time and you're good. We still don't know that part yet. As it stands right now, this vaccine is actually given over 2 doses, right?
The initial 2 vaccines, the Pfizer and the Moderna vaccines, they require 2 doses, 3 to 4 weeks apart. There is another vaccine that is likely to be approved in January that requires only 1 dose. And so we're still waiting to see the final safety and efficacy data of that one. But there's some potential vaccines in the pipeline that might require only 1 dose.
Okay. So, been with CBP for a few years now, and this is obviously, I would go out on a limb and say, one of the most significant events that you've dealt with in your time with CBP, and we all hope that stays the case for a long time. During your time here, switch topics and talk a little bit about your thoughts on CBP. What does it mean for you to be a part of this organization? What does it represent?
Yeah, that's a real thought-provoking question. From day one, I was really impressed by the professionalism and sort of the culture and the mission of CBP. It was a good fit for me, having come from the Navy and the Marine Corps. There's certainly different organizations and different cultures, but some similarities as well. So the professionalism, the pride, the variety of the mission across CBP, from AMO to OFO to BP, but even within, say, Border Patrol, I've had the advantage of being able to travel out and see a lot of operations all along the southwest border, but I've been on the northern border, and I've flown with AMO, and I've been at the airports with OFO, and it's a really diverse mission on the front lines all day, every day, and it's something new every day. You never know what to expect, and I've been pleased by how the medical support has been embraced by the front line as well as by the leadership, and I think we're in the process of building something really exciting that's going to really help CBP operations as well as the workforce.
Well, I couldn't agree more. What do you envision the medical program as Chief Medical Officer CBP? What's the future? What is it going to look like when you walk away to put a stamp on it and say, I accomplished my mission? What does that look like for CBP in the future?
Yeah, we're still kind of thinking and working through that, and we want to develop a real strategic plan and a vision and a mission and an ethos and goals and objectives. So we're looking at that, but I would say to really professionalize it, make sure that the medical support, again, whether it's for operations, the workforce, persons in custody, is done at the highest level that's commensurate with the level at which we operate in our law enforcement functions. I want that same level of professionalism and integrity on the medical side, and I want the level and depth and scope and scale of the medical support to be commensurate with the largest law enforcement agency in the country. And we need to make sure the medical support is on that same scope and scale, and so making sure that we have the right professional medical direction and oversight in place, making sure we have the training, the equipment, the policies, the procedures, the doctrine, all of those, I think, will create a really professional medical support effort.
It's exciting to think about. Any message you want to give to the frontline troops out there?
Just say that we've got your back. CBP Medical is growing and expanding, and we've got your back. If you have any medical issues or questions, please reach out to me or my team. Through your leadership, through your EMS program managers in your sectors, through your sector leadership, through your station leadership. Always want to hear what we can do to help support the front line.
Dr. Tarantino, I want to thank you. We are obviously very fortunate as an agency and as our Green family here and throughout CBP to have you here, especially in this moment in time with what this past year has represented for all of us. Very thankful that you instill a sense of confidence in the direction that we're going and how we're handling it from all of us here at the Academy and throughout the Border Patrol and CBP. Thank you for what you do, and thanks for joining us today.
My pleasure. Thanks for having me.
And that'll do it for another episode. Thanks for joining us from the United States Border Patrol Academy. We'll talk again soon, and honor first.